So how does the body lose heat to cause hypothermia? 4 basic methods. Radiation, infrared radiation, everybody's familiar with it. You've seen the infrared cameras. You know what it looks like. That's infrared heat coming off the body that you cannot see except with the camera. Conduction, you're laying on the ground, you're laying on a slab of concrete, laying out in the snow. The temperature bleeds away from your body. Convection, you heat the air around you, the wind's blowing on you, pulls heat away from your body. Evaporation, not only evaporation from sweat, but evaporation from your breath. The liquid that's in your breath, that's in your lungs, evaporates out of your lungs, also a source of heat loss. This is sort of a basic slide. It's not entirely accurate, but I just wanted to kind of give you an idea where we are. Normal adult body temperature, 98.6, everyone kind of knows that. Mild hypothermia, around 95 degrees. I'll get into more detail about these temperature ranges in a minute. Moderate hypothermia, around 92 degrees. Severe hypothermia, around 86 degrees. And then below that, near death or death temperatures, below 86 degrees Fahrenheit. Initial symptoms of hypothermia. What I want you to remember from this slide is the umbles. Stumbles, mumbles, fumbles, grumbles. We'll talk about those in just a minute. These are the initial symptoms of hypothermia. Shivering, you've all seen it, drowsy, dizzy, withdrawn behavior, they're irritable, they're confused, slow speech, stumbling. They have a stumbling gait, their speech is mumbled, they grumble when you try to help them. They don't want you to be touching them, their skin hurts when you touch them if they're cold. They don't want you to put warm coats on, they grumble with your care. They fumble with their clothing, and you may actually find a patient who's suffering from hypothermia that has fumbled with their clothes and actually taken their clothes off. They're naked. They're cold, but they're naked. So you may find that. Severe stages of hypothermia, they stop shivering. If you find a hypothermic patient that has stopped shivering, you know you have a critical emergency on your hands. You're already in the late stages. They want to lie down and sleep. That's how they die. The heartbeat, breathing gets faint and undetectable sometimes. They may be unconscious, followed by death. You may think they're dead also, but they may not be, so we'll talk about that. Here I categorize a little better this slide. Mild hypothermia, 90 to 95 degrees. Humbles, stumbles, fumbles, grumbles. I want you to remember those 5. Lack of sound judgment. They'll have an increased heart rate, increased respiratory rate. They'll be pale with cool skin. A little bit more severe, moderate hypothermia, temperatures between 80 and 89 degrees Fahrenheit. Uncontrollable shivering, they just cannot stop. No matter if you put a coat on, they just can't stop the shivering. Their umbles get worse. Confused, increased heart rate, increased respiratory rate, cool, pale skin. Severe hypothermia, here's where you get into trouble. Their shivering stops below 80 degrees. They may or may not be unconscious. They may or may not be able to cooperate with your care. They may actually fight you to resist. You're trying to take care of them, and they'll resist. Slower breathing, decreased heart rate, maybe no palpable pulse at all, maybe no obvious respiratory rate. We'll talk more about that. Cold, blue skin. What are the risk factors for developing hypothermia? There are several. Extremes in age, the older population and the youngest population. They're both at risk. The older population loses their ability to thermoregulate, so they can't easily regulate their temperature, and if they're out in the cold, they don't adjust as well as the mid-population does. They may have conditions, medical conditions, that prohibit them from adjusting to their environment. They may not understand that it's cold outside, that they need a jacket. They may have dementia, they may have some orthopedic injury that they can't avoid cold exposure. Young age, like I said, children, especially babies, have a very large surface area to weight ratio. meaning that their skin is able to radiate a lot of heat, so they can lose a lot of heat quickly. But in addition to that, they don't have the heat-producing abilities that adults do. They don't have the big muscle groups that make heat when they're used. So babies can get in trouble very quickly with heat loss. They just can't make the heat. They also have a difficulty. They may not know their environment is harmful to them. They may not know that it's cold outside. They may wander outside and not realize that it's too cold for them to be outside. Might have mental problems, dementia, depression, schizophrenia, who knows, any kind of organic brain disease that might cause you to wander out into the cold without realizing just how cold it is without wearing your coat. Drug and alcohol abuse, every one of us have seen this. You get drunk, you get out in the cold, you get into trouble, you do drugs, you pass out in the cold, get into trouble. Narcotics and alcohol diminish your shivering response, so you may not even know you're getting cold. And all of us know when you drink that alcohol, you just feel warm all over. So they get these risks. Pass out in the weather, be exposed to hypothermia. Like this young lady. Partied a little, I don't know her, so I'm sorry. She passed out at a rave party. She clearly was not dressed for the environment. Certain medical conditions predispose you to developing hypothermia. You have thyroid disease, hypothyroidism, poor nutrition, anorexia. If you're demented, you have Parkinson's disease. You have spinal cord injuries, burns. Several different things can expose you to a risk for hypothermia. Medications, antipsychotics, antidepressants, narcotic medications, sedatives, all of those things, those things you'll be looking for when you see these patients. Oh. The goal for pre-hospital treatment, 3 things. Number 1, to remove the patient from the environment that's causing the cold, move them to a warm environment so that they don't lose any more heat. That's number 1. Number 2, you need to rewarm their core. We'll talk about methods to do that. Number 3, you want to avoid cardiac dysrhythmias, and that's the big killer with hypothermic patients if you're not careful. We'll discuss that in more detail. But you want to do things to avoid cardiac dysrhythmias. Those are your 3 primary concerns when you see these patients in the field. Even conscious patients can develop atrial fibrillation if you're too aggressive with them. For whatever reason, we're not really sure, and it's up for a lot of debate. If you're real aggressive with a hypothermic patient, especially moderately hypothermic and the severely hypothermic, they develop cardiac dysrhythmias, ventricular fibrillation being one of them. So you have to move with these patients very easily. You have to be cautious about jerking off their clothes, the wet clothes, the cold clothes, that kind of thing. And we'll talk more there. If you develop a dysrhythmia in the field with a hypothermia patient, it may be a dysrhythmia that patient cannot recover from. So you play a critical role in whether or not these patients live or die, just by what you do, maybe within the first few minutes what you do. To prevent the dysrhythmias we talked about, gently place these patients in a recumbent position. Make sure that you insulate. If you've got them on a cot, if you've got on a scoop stretcher or something like that, make sure that there's something underneath so they're not laying on a cold piece of steel or aluminum, whatever it is. Remove their clothing. You may have to cut it off piecemeal because if you've got these patients, especially the moderately hyperthermic or severely hyperthermic, and you've got them pulling their coat and their shirts off and standing up and trying to get their pants off, this is all jostling, and you run the risk of developing a cardiac dysrhythmia. Plus, they may not be able to cooperate anyway, so you may have to do it for them. But gently remove their clothing, may have to cut it off. External rewarming using heat packs, hot water bottles, chemical packs. You all know what to do. You all have routines that you follow, protocols that you follow. You know how to do that. Hot packs in the axilla and the groin, sometimes the abdomen, on the neck. You want to try to resist the temptation to warm the extremities aggressively. Talk about that. You want the core temperature to increase, not necessarily the extremities first. You want the core warmed first. So the vital areas where the circulation is. Be aware that you can cause burns with the hot packs. These patients, when they develop hypothermia, sometimes their skin loses the ability to detect temperature. So you may actually burn the skin. They don't even know you're doing that, and they can't tell. In dire circumstances, you might see the police officer that just did this, skin to skin. Somewhere up north, there was a news article, skin to skin in dire circumstances, skin to skin to warm your patient. Has anybody ever had to do that, skin to skin? No. I've never seen it. There's some literature out there that talks about that when you intubate hypothermic patients that they immediately will go into ventricular fibrillation. That's not necessarily true, especially if they're adequately pre-oxygenated like all of us are taught to do. The literature doesn't support it. However, cardiac pacing and atropine are not effective with bradyarrhythmias associated with hypothermia. Don't use them. We'll talk about when you can, but in a severely hypothermic patient and beyond, don't use those. Lidocaine is also ineffective in preventing ventricular fibrillation or ventricular dysrhythmias in hypothermic patients. Don't use it. We use the Swiss staging system most of the time. Most of the literature uses the Swiss staging system, hypothermia 1 through 4. So let's talk about those. Stage 1, mild hypothermia, temperature 90 to 95 degrees, just like we talked a lot ago. They'll be conscious, they'll be shivering. It's very common. First thing you do, ABCs, that's what you do. You get these people out of the cold environment, get them in a warm environment so that you can start the rewarming process. Hot, sweet drinks, sugar is what they need. Your body uses sugar to produce heat. So you need sweet drinks, not Diet Cokes or Diet drinks. They need sugar. Warm fluids. If they have an appropriate airway, they can cooperate, they can communicate with you, they can cooperate in their care. That's what you do. You might encourage them even to exercise. Do some squats, do some standing, marching things, something that will involve the large muscles of the body so that you can produce heat. These are patients that you probably will see and treat and not bring to the emergency room. Stage 2, moderate hypothermia. They might have impaired consciousness, but they may or may not be shivering, depending on where you are on the temperature scale. Let's talk about that a little bit. The core temperature they talk about is a rectal temperature. I can't see any of us flipping a patient over and getting a rectal temperature on these patients. So you kind of have to use your best judgment. The literature talks about using a tympanic thermometer that gives us sort of the best temperature. It's not the best, but sort of the best in the field. Skin temperatures, oral temperatures, axillary temperatures, not very reliable. Certainly not skin. So if you have the ability to do a tympanic temperature, that might be the best. If you want to roll them over and get a rectal temperature, it's on you. If you have a stage 2 patient who appears impaired, they're not shivering. If they're not shivering, you know you're in trouble already. So rewarming with the external rewarming techniques. Do y'all have humidified oxygen, humidified warm? Y'all can have the capability. I'm sorry?
We have the ability to humidify, but not warm it.
Not warmed. Ideally would be warmed. Again, respiration, heat loss. I'm sorry?
You said we take a hot pack to the...
Take a hot pack. Warm IV fluids, warm to 100 to 108 degrees. I don't know if y'all carry warm fluids on the trucks or not. You do? Somebody nod yes. You want to start your IVs for these fluids as close to the core as possible. Specific anticubital. Don't get aggressive and really start EJs and IJs and that kind of stuff if you don't have to. But you don't want to start IVs in the periphery because those tissues are really, really cold. And even though you're infusing warm fluids, the tissue is going to cool that fluid. And that cool fluid is going to go to the core. We'll talk about after drop in a little bit, but that's what happens with that. So try to get as close to the core as you can with your fluids. Be cautious about your movements to avoid the dysrhythmias. Get the cold clothes off of them, wet clothes. Definitely cardiac monitoring, definitely in a warm environment. Chemical pack, just like we talked about. This one. Stage 3. Temperature 75 to 82 degrees Fahrenheit. Again, you're not going to be able to know that temperature, so use your best judgment. You might be able to get a tympanic temperature. They may be unconscious. Their vital signs will be present or very weakly present. The risk of cardiac arrest in these patients is huge. We're not really sure the mechanism why, but it is. Assess their status for 60 seconds. Most of us are taught to assess vital signs for 10 to 15 seconds in the field. You got to use 60 seconds because their pulse may be 20, they're 30. You may not even feel it if you feel for 10 seconds. You'll miss their pulse, you'll think they're dead. Or you'll assess the respiratory rate, which is 5, and you won't even know that they're breathing, but they are. And you could save them. If you declare them dead immediately within 10 seconds, you may be mistreating the patient. So use the full 60 seconds, evaluate a weak, maybe partially present pulse and respiratory rate. Same management in this case, with the severe hypothermia as you would with the moderately severe hypothermia. Warm packs, warm environment, sleeping bag, warm towels, warm sheet, warm blankets, whatever you have. Reflective blankets, I see those a lot. In the severe hypothermia patients, reflective blankets reflect the heat of the body back. That's the way they're designed. These patients don't have heat coming off their body, so they're useless. So don't even worry about a reflective blanket. You're just wasting your time. You might have to make the decision if they have wet clothing whether or not you want to get all that clothing off or you need to scoop and run. So if they're soaking wet, they've been submerged, or it's a partial drowning or something like that, you may just pack them in warm blankets and start warm fluids and get going and not worry about the cold, wet clothes. I'll worry about that. Apparent death, stage 4, the worst part. They may have minimal or absent vital signs. You may not feel a pulse, you may not see any respirations whatsoever. They're going to look dead. They'll have pale, blue skin, they'll look dead. The first thing you need to do with these patients is to assess to see if they have some other injury or some other event that makes them unrecoverable. They have a traumatic brain injury or a traumatic chest or abdominal injury, gunshot to the head, something like that, in addition to the hypothermia. If you see something like that, a non-recoverable patient from another injury, you're probably not going to do any good by addressing their hypothermia. If you don't find anything like that, then you can move on. One of the things people look for, compressible chest. If you cannot compress their chest because they're frozen or their belly's frozen, that's a good sign that you don't need to do anything here. Call me, tell me you've got a BOA. Same management as stage 2 and stage 3 with CPR. So you've got a patient who looks dead, whose temperature might be in the 70s, no pulse, no respirations, and you're thinking, they're dead. I don't need to do anything. Please don't do that. At least try a little bit, start CPR, intubate the patient, start warm fluids. Again, the ACLS drugs, I checked the most recent AHA recommendations. They recommend only 3 doses of epinephrine use, no lidocaine, no atropine, nothing like that. Use 3 doses of epinephrine, defibrillate once, 200 joules. That's it. Don't waste any more time. If you develop an asystole rhythm or a cardiac rhythm in the field, they probably won't reemerge from that, no matter what you do, until we rewarm the heart. So don't waste your time. Do your CPR, do your ventilations, do all the rewarming stuff, get them to a place so we can take care of it. Don't abandon resuscitation without a good reason. The record standing right now is 6.5 hours of CPR, fully recovered. Fully recovered. No neurologic findings, fully recovered. His physician actually went down. Everyone knows this phrase, not dead into warm and dead. There's a lot of discussion about what warm is and where you stop that. You don't have to worry about that so much because you're not going to make that determination in the field. But it's right around 90 degrees, at least from what I can read in the literature. You want to get them to stage 1 out of stage 4 before you call it. Let's talk a little bit about after drop. We mentioned it. You get these patients, they're mildly or moderately hypothermic. You start your routine, warm fluids, warm blankets. You get them in the truck, you start working on them, and they crash on you after 10 or 15 minutes. It's because the fluids in their extremities are now that you're starting to warm them up, they start to vasodilate. And when they vasodilate, the fluids in their extremities start rushing back towards the core. Those fluids are cold, probably colder than what the core was to begin with. So now the temperature of the core actually drops. So they get worse while you're doing things to make them better. They also have acidotic fluids in their periphery, lowers the pH. So you're wondering, what did I do wrong? It's called after drop. It doesn't happen always, but it is a risk. Outcome of these patients. You as pre-hospital providers can make a significant impact in the people that you take care of. If you recognize and treat appropriately, 100% of these people can survive without neurologic injury. If you delay or if you don't recognize it, 50% of those people will die. So you can make a great impact by doing the job that you know already how to do. That's down and dirty hypothermia. Questions? We'll move on to hyperthermia.
What rank is that?
That is the Helmut Hooker. It's in Bon Air. My absolute favorite dive site by far.
It is.
Is that you?
My wife never was not me. It's my wife.
Not here. Yeah, I see on here, so that's my first question.
So about 100 feet deep. It's an awesome place. Questions, anybody? We'll move on. Let's talk about hyperthermia, other end of the scale. Hyperthermia, elevated body temperature due to failed thermal regulation. The body produces and absorbs more heat than it can dissipate. Thus, the temperature rises. That's the definition of hyperthermia. The human body, as we just determined, is really resilient when it comes to cold. You can change body temperature by 20 or 30 degrees and still survive. With heat, it's not so. About 9 degrees is all we can tolerate. Heat change. We have multiple mechanisms, just like before, to dissipate our heat. Same ones. Evaporation, which is the most effective mechanism that the human body has for dissipating heat. Radiation, convection, conduction, all the same as cold. When the external temperature gets greater than 95 degrees, we lose the ability to radiate heat from our bodies. So we solely rely on evaporation. When the humidity gets high, then we start to lose the ability to evaporate. So in an environment with high humidity and high temperature, like we have around here all the time in the summertime, the body loses both of its mechanisms to dissipate heat, and you overheat.
That's what cold beer is for.
What?
Cold beer.
Cold beer? Absolutely. So let's talk about heat emergencies. Heat cramps first. The risk factors for all the heat illnesses are all the things that you all know. Strenuous activity in high heat, high humidity environments. Your environment that you work in when you do rescue, that may be high heat, high humidity. Just think about that. Lack of acclimation, poor physical fitness, obesity, dehydration, antihistamines, decongestants, and antidepressants. People take those medications and go out and, play touch football for 3 hours and fall over. Ethanol, of course. Illicit drugs, of course. Put you at risk for heat injuries. There are many more. I didn't list all of them, but there are a whole lot more. So what are the primary mechanisms that the body uses to try to dissipate heat? We vasodilate. Blood vessels in our skin vasodilate, exposes warm blood to the atmosphere, tries to cool it off. We decrease our heat production. You get lazy and tired. You don't want to work out in the heat so long. We decrease our heat production. We increase our heat production. Increase our sweat production. I'm sorry. Increase the sweat production, decrease our heat production. Sweating, obviously, evaporation gets rid of the temperature. Behavioral heat control. You're like this guy. He doesn't want to stay out in the heat anymore. He wants air conditioning. So he goes inside. He makes the conscious decision to go inside. So it's behavioral as well. Okay, heat cramps. First, heat injury. These people will have a normal body temperature. They will not look dehydrated or have signs of dehydration. They have painful, involuntary, spasmodic contractions of their skeletal muscle, usually the calves. And every one of us here has seen this. Most of us probably had it. Shoulders may be involved, thighs may be involved. We don't really know the exact cause of why these muscles contract like that. We suspect it's electrolyte related. The literature is all over the place as the cause. Cramps are usually in individuals who've been sweating profusely and they've been drinking water or some type of hypotonic solution, with the understanding that the loss of water and sodium are the main culprits here. They can occur during exercise, but more commonly they occur after you've been in a period of rest after a vigorous exercise. So a few hours after you've worked out in the yard is when you start getting the cramps in your legs. What do you do to treat the heat cramps? If you get a call out, somebody's legs are cramping or their shoulders are cramping. All the typical stuff that you normally do. ABCs first, do a second survey, check the blood sugar, see what their blood sugar is. They've been out exercising or playing, or they've been drunk all night, or who knows what. Check the blood sugar, start your cooling processes. Get them in a cool environment. Remove any restrictive clothing. If they've been out welding, take their welding clothes off, get all that off. If they have an altered level of consciousness or other severe symptoms, then you may not be dealing with just stage 1 heat cramps. So think about that. Cool wet towels, cold packs, cold mist spray, all the stuff that you can do in the back of your truck or in their living room. But don't let the cooling delay. If you think that they need to be evaluated in the emergency room and it's more than just heat cramps, don't try to cool them for 30 minutes and then decide you need to go. Just go ahead and go. I'd rather you come in and it's nothing than to wait too long and then I have more to do. You want to PO challenge these people? You'd like to drink some kind of saline solution. You can make one. I asked you all to carry the salt tablets. Some events do carry salt tablets, but you can make saline with a tablespoon of salt or a teaspoon of salt in a quart of water. And you want them to drink small sips of that. They may need to drink the whole quart to do that. The commercially available sports drinks, your Gatorades, and all those are fine too. Not the monster drinks. Don't do that. Like that. If they're a little more severe than just oral hydration or they're nauseated, they can't drink the fluids, you may have to start an IV and start fluids. Don't say that. Ideally, those patients you can treat at home and not have to bring them in. Their cramps will resolve, and their temperature is normal anyway, so you don't have to do much. Second, heat illness, heat exhaustion. This is more severe and it's a medical emergency. caused by loss of water and sodium through sweating. What are their symptoms? You've all seen it. Probably had it when you were mowing your yard. Nausea, dizziness, headache, weakness, high body temperature. Generally, these patients, by definition, have a core temperature of less than 104 degrees. Again, you're going to roll them over into a rectal temp. The key factor here is they don't have CNS symptoms. They haven't had a seizure. They're able to communicate with you. They're able to cooperate in their care and your evaluation. They don't have delirium. That takes them into the worst part, and we'll talk about that in a little bit. So if they have those symptoms, if they have an altered level of consciousness and their temperature is 103, I don't care that their temperature is 103. You've got to move into the lower stages of heat illness. So mental status is a big thing to evaluate on these patients because that's the deciding factor for me. And we'll talk about the graphs that everybody's seen here in just a minute. We've all been there, mowing the yard. Our temperature was 103, probably. We're out in the sun. Had a few beers the night before and didn't replace our fluids. High pulse, low blood pressure. Everybody talks about, and all the literature they talk about, the moist skin and the sweating versus heat stroke, and we'll get to that in a minute. That is a poor prognostic sign and a poor decision-making process for these patients. I personally can't, and I don't think you're going to be able to look at a patient and say, well, they're not sweating, or they are sweating, so it's not heat stroke. Or they're not sweating, and it is heat stroke. I don't think you can make that determination in the field that easily. So you have to use all of your senses available to you and evaluate these patients. Because this is what, but generally less than 104 degrees. This guy, you're probably going to have to bring to the emergency room. He's obviously dehydrated. His pulse is probably rapid. His blood pressure is probably low. Rapid cooling for heat exhaustion. The literature makes a really big deal about this, and schools are starting to catch on with this. Football teams. Rapid cooling if you suspect somebody with heat exhaustion. That means an ice bath. That's what that means. If they have the capability to do a rapid cool bath for 15 to 20 minutes in ice, it really makes a humongous difference in the outcome of these patients. So if they can cooperate, they have a good airway, they can assist you in getting in and out of the tub, they're not so hypotensive that they're blacking out, those types of things, then a rapid cooling session in a tub is the best thing available for these patients. If you respond to a ball game where somebody's gone down on the field, you diagnose hypothermia. If you can get them in a cool tub, do it. You want to see them treated as soon as possible, generally within 30 minutes. These probably are not the best methods to cool your body down. I thought the picture was kind of cute. This is what you want. You want to monitor the vital signs, monitor their blood pressure. I think these thermometers are actually core thermometers, core temperature thermometers. I certainly don't want a probe in the dark regions of my body. So do the best you can with monitoring the temperature. But 15 to 20 minutes. 15 to 20 minutes of a cool bath will drop your temperature by 5 to 7 degrees. So you're going to get out of that lethal range quickly. You're shooting for 102 degrees. Again, you've got to have core temperature on that. So oral temperature, axillary temperature may not tell you 102 degrees. The key is if the patient starts shivering, it's time to get out of the cool bath because shivering does what? Produces heat. So you're just making the situation worse.
Hey, Doc, weren't they, I don't know if it's been years and years, but weren't they worried about dropping temperatures too fast?
Yes.
Because of seizures?
Yes, there is the risk, and that's one of the risks. You drop the temperature too fast, and that's why they talk about only 15 or 20 minutes and then the shivering. You have to at least use your senses about you and You're constantly evaluating the patient. But, yes, they do. But the literature I just checked for this year, do it.
All right.
Do it.
Medicated, yeah.
Yeah. Oral fluids, if they can cooperate, that's what you want for them to drink. You might have to go to IV fluids. All your standard protocols apply here, all your ATLS and your BLS and your PALS protocols for fluids. Normal saline or lactated ringers, 20 milligrams per kilogram in pediatric cases. All the stuff that you already know applies here when you're treating these patients. Do not use cooled fluids. Somebody asked me that one time. Don't freeze or throw some fluids in the refrigerator and try to infuse that. Don't do that. Why don't you do that? One of the reasons.
Shock to the system.
Shock to the system, and what will that cause?
Arrhythmias.
I'm sorry?
Cause dysrhythmias.
Dysrhythmias. You have a patient that's got a temperature of 104, but they're having dysrhythmias in their heart. Again, all ages, if they're still symptomatic, give them a second bolus of fluids, oral or IV. Heat stroke, last one. Temperature above 104 degrees. Again, that's a core temperature, so you're going to have difficulty determining that temperature. You can't walk up and say, well, you've got heat stroke because your temperature is 105. You're not going to be able to make that determination. So you use symptoms. Throbbing headache, dizziness, lightheaded. They're confused. They may have tachycardia, tachypnea. They may have seizures. They may be unconscious. So use your diagnostic skills to assess the patient. Everybody sees this diagram. Everywhere you go when you talk about heat stroke versus heat exhaustion, this diagram is everywhere, and they talk about the hot, dry skin versus the sweaty, cold, clammy skin. I will tell you, at least in my practice, you can't tell the difference. You might have a patient that has a temperature of 105 degrees, is having heat stroke, who's sweating because they've just crossed the threshold. So if you evaluate a patient, you think, well, they're sweating, so they can't be heat stroke. Don't make that mistake. Use your skills and evaluate these patients. If you can get a good, accurate temperature, that's great. Pupils can be constricted or dilated if these patients are using substances. They're drunk, you may not know. So this diagram, although it's been published time and time and time again to tell the difference, is not very helpful for me. Some of the common things for heat stroke: coma, seizures, dizziness. You see those things, you automatically know. You don't have to do any other diagnostic skills. If they've had a seizure and they're really confused, good. And they look like they have a temperature that's above 104. That's heat stroke until proved otherwise. Treat it as such. I would rather you over-treat than under. Morbidity and mortality. Here's where you come in to play. The morbidity and mortality of heat stroke can be as high as 80% without accurate diagnosis and treatment. But you can reduce that to 10% if you treat them rapidly and correctly. So you can have a major impact on the population that you treat before you even get to me. That's why it's important. Because you've made a play in the game on these things from the get-go. Treatment for heat strokes: if you have a patient that's incapacitated, they're unconscious, they've had a seizure, they just won't cooperate, they're delusional, you may have to resort to cool packs like this in your truck. You may have to fight them to do that. They won't like it. You do all of your BLS and ALS protocols just as normal, fluids, all the things that you do, cardiac monitor. Try the best you can with those patients. They're difficult at times. And get them to me as fast as you can. Because you're not going to dump a 80-year-old demented patient in a cold tub. She'll beat you to death. Try to do that. And the treatment's the same. Treat heat stroke as it is with heat exhaustion. Fluids, oral or IV, probably IV. That's it.
Thank you, Doc.
Questions? Thank you, sir. Not bad. Anybody got any questions about today?
Need to make sure everybody has a quiz filled out from this and the instructor evaluation form. Everybody that's watching remotely, I'll get the quizzes out to you as soon as I can. I'll be coming around to all the departments on Tuesday, pick up all the paperwork. Anybody has any questions, please feel free to contact me at any time. Most everybody's got either my cell phone or my email, so.
Have a good week.
Do us again soon.
Thank you, sir.
Hey, thanks, Mom.